We'll start recording. So hi everyone, this is the lecture on the neuro logic system and the neuro content. This is the second half or part of the neuro alterations of the nervous system. And we will continue with seizure attacks or seizures of convulsions, Parkinson's disease, and ALS. And stroke, different types, CVA or stroke, and spinal cord injuries, traumatic brain injuries. That will be the content for for today's lecture. So we'll briefly go on. We'll cover, hope we can cover all the aspects or all content areas. So this will be the second part of the nervous system or alterations of the diseases or the pathophysiological alterations of the nervous system. So the any questions before, like from previous content, from because we did cover the part one for the nervous system, and this will be the second part. So I'll go ahead and share the screen. Okay, so this is the where we stopped or left at, which is the seizures, and we said, I'm sorry, so starting this new content. So anyone had experience with patients with seizures, or have any maybe somebody who had the seizure attacks or epilepsy or convulsions, or if you can just try to, who wants to give us some feedback or anything that input, I would say, about the seizures. Adriana, go ahead.
My mom had one, so when she had one, she couldn't really talk, but like she was trying. She had a lot of convulsion. But it wasn't like a shaking one. You know what I mean?
Right. Yes. Yeah. It was more tonic, just contraction.
Yeah.
With no like not a jerky movement, like a convulsion, tonic, clonic. That's called tonic, which is contraction. Clonic, which is like relaxation. So like a jerky movement, that's a tonic clonic. This one was a more contraction, kind of. Right? Yeah. Any frothy, secretions in the, out of the mouth.
Yeah.
Biting the tongue.
Yeah.
And breathing, like airway obstruction or airway problems.
Kind of, but she could get like a little bit of word out, but not really.
Okay, so this arteria, which is unable to, communicate in words. Okay, yeah. Right. Yeah. Any other input from about the convulsions or seizures or epilepsy?
I just want to add, like seizure is so common, like 6 in 10 people have seizure, and many of us don't notice that we are having a seizure. We may feel like headache, but sometimes it's actually a seizure.
Yeah, there are too many forms of the seizure. Yeah.
My grandmother used to get them, and there were times where she would just kind of have this blank look on her face.
Okay, staring spells, we call it.
Right.
Yeah.
And then like she would do that for a little bit, and then all of a sudden she would just kind of like pass out, like just
Yeah, with children, that would be more with the children. When you see the staring spell, it's kind of like stare at something or at you or something for a few seconds. It shouldn't exceed like a minute, but it's for less than a minute. They stare at something, they do not change that gaze for for 20, 30 seconds, but less than a minute. And they will do that like frequent, 100 times during the day. That is one type of seizure attacks as well. There are too many, as Chital said, too many types of seizures and too many, because the seizure, as we define the seizure in pathophysiology, we say it's a sudden transient alteration of brain function caused by abrupt, explosive, disorderly discharge. So which means that there is a discharge, electrical activity that has been discharged, and that results in through the cerebral neurons and result in the symptoms. So the symptoms you see as being exemplified or being exhibited by the patient, that's in response to that sudden changes or alterations in the electrical activity or electrical activity in the brain cells. So and there's a difference between seizures and convulsions and epilepsy, and we'll see the difference between them in a minute. So the convulsions, it's either tonic-clonic, it's like kind of like a jerky contract and relaxation, contraction and relaxation, and tonic-clonic movement associated with some seizures. That is, some of the types of seizures is associated with the tonic-clonic type. We also have something called partial seizures or generalized seizures. Partial seizures, it's also, there's a subclassification under partial. Simple, complex, secondary generalized. There's also subclassifications. And under generalized seizures, it's generalized, which involve the entire brain. Electrical discharge will involve the brain cells, all brain cells almost. And it's the and something called unclassified seizure attacks or unclassified epileptic seizures. The unclassified is like idiopathic. So what do we mean by idiopathic? When you say idiopathic from chapter 2 or from the first foundational concepts and terminology in pathophysiology, we say idiopathic. You knew when, okay, go ahead. Idiopathic means?
Is it when you don't know the reason for a disease?
Right, yes, which is, we don't know the underlying cause for the disease. When we have no clue what caused the disease, we say idiopathic. But we have specified, etiologies, specific etiology, specific cause, then it is not idiopathic. You know what has caused this disease. This disease resulted from the following causes. But when it's unclassified seizures, then sometimes it's because it's idiopathic. We don't know what has caused the seizures. So we have the primary and the secondary seizures. Another classification called primary seizures and versus the secondary seizures. Primary seizures, idiopathic, unclassified is one of them. Or, which is accounts for, first of all, the idiopathic one, which is unclassified, which is the unknown cause. It accounts for about 50 to 75% of all seizures. In other words, that there's it's not associated with any identifiable brain lesions or any other specific cause, and cannot be attributed to specific cause. So secondary seizures, which will result from the underlying problems like brain lesions, tumors, adenomas, and these causes, usually it's caused by another factors like head injury, traumatic brain injury, CVA, stroke, sometimes even would result in this. Maybe it would result from the metabolic disturbances, electrolyte disturbances. So the seizures resulting from systemic and metabolic disturbances are not considered epilepsy, because sometimes the people, they use the epilepsy and the seizures like they are interchangeably kind of use concepts or terminologies. They are not the same term, term to be used. We use epilepsy in certain scenarios and seizures in a different scenario. So epilepsy may result from various causes. Epilepsy, like metabolic defects, congenital reason, like congenital, genetic, or from like, birth injury, prenatal injury, or postnatal trauma after birth or during birth. I mean, during the neonatal life and during pregnancy, or could result from brain tumors. So the seizures resulted from systemic and metabolic disturbances. They are not considered epilepsy. If the seizure cease when the underlying problem is corrected. So as long as you know what caused this seizure and has been corrected, you cannot call it epilepsy. So the definition of the epilepsy would be, because that's according to the National Institute of the Neurological Disorders and Stroke, they define epilepsy as 2 or more seizures experienced by a person that is then can be called epilepsy. One isolated seizure attack or 2 won't define or put the patient to be classified as a patient with epilepsy. So as long as it is exceeded the 2 or more seizures, then that can be called epilepsy. It's just the frequency that would define the epilepsy versus the seizure attack. Now, the common causes or the etiologies for the seizures, that's we can classify it also according to the age group, like 20 to 30 years old. Then most of the cases would develop the seizures due to the structural lesions, like brain tumors, traumatic brain injuries, vascular problems. And after 50 years old, then we will refer that or say that the epilepsy could be or much. So this is more prevalent. I mean, the prevalence or the number of cases, they found that the majority of that age group, they develop the epilepsy due to the following factors, and then the majority of the patients over age of 50, they develop that due to CVA or stroke, and also metastasis of cancer cells metastasize from, let's say, like from liver to the brain, and that's metastatic brain tumors. So that's also would be common in patients over 50. And we can also add to the definitions of epilepsy, it's a condition for which no underlying correctable cause of the seizure can be found. That we, in conditions in which that you cannot identify the causes or factors has resulted in the seizure attack, you can call it epilepsy. In addition to the frequency, 2 or more seizure attacks. So in which that you can add like 2 criteria to say that patient has an epilepsy: the frequency, more than 2 seizures, and seizures that you can identify the causes, the etiologies. So it's not because the patient has a head trauma and that's why patient developed the seizures. It's patient never had no history of congenital or genetic, or patient doesn't have a history of any other metabolic disturbances that has resulted in seizures. So we cannot. So in other words, that a condition for which no underlying correctable cause of the seizure can be found. That's another criteria to classify or to identify the epilepsy. So generalized seizures, we have different types of generalized seizures. The first one is the most common one, which is the tonic-clonic seizures, in which that the patient will have that jerky movement, and they have, we call it ictal. All seizures or seizure attacks, patient would have that attack. So the seizure, which is referred to that as ictal, ICTAL, pre-ictal, and then post-ictal. Pre-ictal, which is some of the patients who had the epilepsy or seizures, they would attest to this, saying that, you know, I see like flashlight, I can feel, I can, you know, I smell something, I do. So that's kind of, you know, that's the pre-ictal, or what's called the aura or prodroma, which is the things that patient experience before the attack, before the seizure attack. And that's kind of like a warning sign. And sometimes helps with, you know, us and them to prevent these attacks from happening. So it's a wide range of things. Either can, you know, can be like, you know, feel, you know, certain sensations, feelings, smell, see something, you know, on the visual field or in the back of, you know, the visual field, or that's, you know, things that patient experience before the seizure attacks, like a warning sign, aura or prodroma. And then we have an patient after the ictal, which is the actual seizure attack, and then post-ictal, which is after the phase after the attack. Post-ictal, which is most of the time, almost like all patients, especially with the tonic-clonic type, because it's a jerky movement and affects all the muscles of the internal skeletal muscles of the body, contract and relax, contract. So that's kind of continuous, constant, like, you know, for a few minutes. It can go up to like maybe 5 or 10 minutes. So the post-ictal experience, the patient will, so that is characterized by muscle soreness, like fatigue, muscle pain, and that the patient may sleep for hours after that. Because that, you know, the seizure attacks involves the skeletal muscles, which resulted in the lactic acidosis, and the lactic, you know, acid that's being produced and cause that soreness of the muscles and the fatigue, and they are really tired. So that's would result in that you know, they will sleep for hours after the attack. The other type is called typical absence seizure, which is the petit mal. That's another name for the seizure. It's called petit mal, and it's one of the one form of that petit mal would be like what's called the steering spell, and it affects most of the children. It's associated also with a brief loss of consciousness, and if that happens with a child, like more than, I mean, experiencing that steering spell, staring at like one thing for a few seconds and goes up to like less than a minute, that sometimes it happens and goes up to like 100 times a day if untreated. So that's something to consider for you to be like that's a seizure attack or one type of seizures, and especially when there is a brief loss of consciousness. Too many types or, you know, forms of the seizures. We have atypical absence seizure, myoclonic seizure, in which that with the myoclonic seizures that can be forceful enough to cause that the patient to fall, and that's when they may experience an injury, especially head injury. Akinetic, atonic, or static, which is all one type. We call that also it's called also a drop attacks, because patient will faint and then they will fall, and the consciousness usually returns after the person, they like hit the ground, and then they can resume normal activity, and that's kind of common for the akinetic or the atonic, or what is called the ecstatic, and that's another one is great for, I mean, risk for the head injury. We have also partial seizures and epileptogenic focus, which is the specific group of neurons that are hypersensitive to the paroxysmal depolarization shift. These neurons are easily activated, and the activation of these neurons can be by, for example, electrolyte imbalances like hyponatremia. So that's why some patients with hyponatremia or hypernatremia, but mostly hyponatremia, develop the seizures because of that epileptogenic focus that is sensitive to the changes in the electrolytes, especially sodium. Patients may lose consciousness and develop the seizure attack also from hypoglycemia, severe hypoglycemia, like less than 50. blood sugars, plasma blood sugars. Hypoxia or hyperthermia. And that's most, would mostly affect the children that may, like peds, is very dangerous for, for peds to, that we ignore their hyperthermia and fever, because that could result in not just brain and in the seizures or, or epilepsy that can be acute or chronic, but also can result in cerebral palsy, CP, from untreated hyperthermia in children, especially neonates. So, and we said two different types of symptoms or signals that would come pre or before the attack. And we said we have an aura and prodroma. And we explained the tonic-clonic. The tonic is the contraction, the clonic is the relaxation, and that will give the characteristic of the seizures as a jerky movement, tonic-clonic. So you can also look at the seizures as symptoms of epilepsy. That's another way of how would you connect seizures and epilepsy. In other words, that having a single seizure doesn't necessarily mean that the patient or a person has an epilepsy, which is like an isolated seizure attack in response to certain factor. And during pregnancy, pregnant woman may develop the seizure attack, which is in this case called eclampsia. Eclampsia is which is like a toxic pregnancy. It's called eclampsia is a form or an example of seizures. Eclampsia, ECLAMPSIA, eclampsia. They are examples of seizures that are not associated with epilepsy, but they are episodic, isolated, and that just they occur during the pregnancy. Now the alterations in cerebral hemodynamics, changes in the brain pressure, we call it intracranial pressure. So first of all, what's the composition or what constitutes this pressure? What's the source of that pressure? Why we have a pressure in the brain or in the cranium? Actually, it's not just the brain, it's in the cranium. We have pressure inside that cranial vault or in the cranium called ICP. And the source of the ICP is due to the presence of three things: blood, brain tissue, and CSF fluid. And here you have the percentage for each component. The brain tissue, which consists of the majority of the pressure, the source of the pressure of the ICP and the cranium, about 78% is due to the presence of brain cells, the brain. Blood in the blood vessels within the brain tissue, we have it up to 12%, and CSF fluid accounts for about 10% of that ICP. So the ICP should range between 10, not to exceed 15. Otherwise, we will call it increased ICP. So what's the danger of increased ICP? We always say, and we're very careful with with the ICP measures and numbers and values, and we always discuss the factors that will increase ICP. We try our best to prevent it. What is the danger of the increased ICP? In other words, what would be the complications of increased ICP, elevated ICP?
Headache.
Like the brain, like
Okay, symptoms like headache, that's the least symptoms, which is, okay, that's a warning sign, which is good, can be one of the first signs. But what's the complications beyond the headache?
Like it could
Hormones.
damage,
An
it could damage the
inflammation?
brain.
Janet and then Amy. Janet.
It could damage the brain.
Yes, brain cell damage will result. It's not imminent or, like, the first step. It takes a while, but at least it's stages. The first stage will be increased pressure. In other words, that it will increase the pressure against the blood vessels in the brain, cause vasoconstriction, decrease perfusion to the cells, brain swelling in response to that, cerebral edema would result, and then herniation, in other words, which is the pressure on one side of the brain. So the sequel of events is very dangerous when it comes to increased ICP. We'll cover that in a few minutes. So the factors will increase the ICP, too many. Even posture, we have something called, I'm not sure I include that. Yeah, it's right here. It's called modified Monroe-Kelly doctrine. This is one of the compensatory mechanisms, or the compensations, or it's like a rule in the brain or in the cranium that govern and control the ICP. Which means that just always remember the three components. The brain, there's always a room for compensation. It doesn't mean that, the factors, because I listed the factors here as atrial pressure, venous pressure, the intra-abdominal pressure, doesn't mean like, every time we cough or sneeze or like, bending or stooping or sitting or changing position from sitting to standing or posture changes is going to result in increased ICP. There is always room for compensation based on the principle called the modified Monroe-Kelly doctrine. This kind of like a rule that governs the homeostasis in the brain, which will maintain the ICP within range. The detrimental changes for the ICP would be, for example, the head trauma, traumatic brain injury, CVA or stroke. That will be like significant changes or brain tumor, electrolyte imbalances, severe electrolyte imbalances, like severe hyponatremia, for example. So in these scenarios, you'll find that the ICP would increase. So just this slide explains that the changes in one of the three elements will dictate changes in the other two to maintain the homeostasis. One example of that. And I'll give you an example. So before I get to this, an example of how a change in one factor would result in change in the other factors, remember that the CO2, carbon dioxide, is a vasodilator. So the carbon dioxide, it will dilate the blood vessels in the brain, which means more CO2. So if you like bradypnea, decreased rate of respiration, bradypnea will result in CO2 accumulation. CO2 accumulated in the blood vessels will result in vasodilatation, and that will increase the blood volume in the cranium, in the brain, and then that will increase the ICP. Well, if you have, then the other two components supposed to compensate for this ICP increase, slight increase, this very minimal increase, if that's very minimal. Then the CSF supposed to decrease its production or increase the excretion, or reabsorption. So either to decrease the production, which is secretion, or increase its reabsorption. It's just, this is some of the modifications from the CSF fluid in response to the changes in other factors. Nothing can be done for the brain cells to increase or decrease because the brain cell size doesn't have much of room for changes except for the fluid, right, to enter the cells. That can be the case, but just I know it's a very complex kind of concept here, but it's just to give you to understand that the This rule govern and control the homeostasis in the brain to maintain the ICP within range. So one change, so we have three components: brain cells or brain tissue, blood, CSF. One change or any change in one of these components that resulted in, which has resulted in increased ICP, the other two components supposed to compensate and to bring the ICP back to normal. And that's what you need to know about this, because I know it's a very complicated concept here. So homeostasis is governed that way, or is determined by the three components. ICP will be maintained within range until it exceeds. There is, scenarios that, the brain cells and blood and CSF fluid cannot guarantee that doctrine to maintain the homeostasis and maintain the ICP within range. And then all of a sudden that will exceed the 15. And this would be like scenario that would be a brain tumor. If there's like, 10 or 15, 20 centimeters of brain tumor, then that's not going, to be maintained. The ICP is going, definitely is going to be, would go up and higher than 15. Or traumatic brain injury, or patient who developed intracerebral hemorrhage, bleeding within the brain cells. Homeostasis will be impossible given the normal physiological factors and functions. So that's why you will see that elevation in the ICP in these scenarios. Examples of when ICP would elevate, like I give some examples like mass, lesion, or brain tumors, edema or cerebral edema, or swelling in the brain cells, head trauma or traumatic brain injuries, inflammatory processes in the brain cells, and the metabolic insult. The problem here with the ICP is the sustained increase in ICP. Continuous sustained increase in ICP would result in what is called brain stem compression and herniation of the brain from one compartment to another. Like the brain will be herniated from one side to the other, from right side to the left side. And that will be very dangerous. And the increase in ICP physiological changes would be in decreased perfusion because of that pressure on the blood vessels, leads to tissue hypoxia, and then that will result in decreased serum pH, acidosis. It will increase the CO2, and the CO2, we said it's a vasodilator, so it will bring more blood to the blood vessels, result in edema, and then that will further increase the ICP. So that's kind of like sequel of events from the increased ICP to why it is become like sustained increased ICP. Unless you treat the underlying cause, it will continue to go higher and higher because of this sequel of events, from decreased perfusion down to the edema and the vasodilatation and increased CO2. So sustained increased ICP would result from this sequel of events, from decreased perfusion, which result in decreased tissue hypoxia, which will decrease the pH of the blood, and serum pH would drop, acidotic, increase CO2 level. And we said that the CO2 is a vasodilator, so it will bring more blood to the brain cells, become swelling and edema, and that will further increase the ICP. So this explains the sustained increased ICP, and if untreated, that will result in brain herniation syndrome, and that is irreversible brain damage.
That would, Professor, could lead the patient to be like in a vegetative state and just. Okay.
Yes. Yeah, I'll get to that in a minute. Yes.
Sorry.
Right. No, it's okay. But that's, it's a very complicated concept, and it's very like, it's very comprehensive, because we have also stages of intracranial hypertension and the stages of herniation, and it's a lot of content associated with that. Let's just stick to the basis and to the foundation of the increased ICP, the factors and the sequelae of events, and the I won't even cover the management, because management will be part of the adult health 2 and adult health 3. So for the increased ICP. So the cerebral edema, which is the increase in fluid, which is like fluid retention within the brain cells. And we have 4 different types of cerebral edema. When the brain cells become swollen and edematous, either it's vasogenic, cytotoxic, interstitial, ischemic. Now the vasogenic edema, which would result, and that's most common type, the vasogenic edema, and it would result the fluid collected in the brain cells. The mechanism is that the abnormal permeability of the brain blood vessels. So cerebral blood vessels become more permeable to the plasma, to the fluids, and that will allow for more protein-rich formula to infiltrate and to collect in the extracellular space of the brain. In other words, that the fluid will be collected inside the brain cells. That's why there will be brain swelling. So that which is due to the increased permeability of the brain cells and of the blood vessels in the brain, allow more fluid to leak through. The second one is it's called cytotoxic, and the cytotoxic is due to the hypoxic insult, like hypoxia cause, which was the disturbance in cell metabolism. The metabolism affected, then it will affect the sodium pump, and then that results in that fluid and sodium, sodium and fluid will be collected in the brain cells. So the sodium pump fails, and the sodium will enter the cell, and it pulls the fluid also will follow. So we have more fluids collected. That's why we call that cytotoxic cerebral edema metabolic, which is always connected with sodium pump failure and fluid entering the cells. Interstitial cerebral edema, which is from the word interstitial. It will result when there is an increased blood pressure or CSF pressure. Like patients with hydrocephalus, when they have lots of CSF fluid, either it's obstructed or produced, they would have this type of interstitial cerebral edema. Or patients with malignant hypertension, extremely high blood pressure, 220 over like 140. They may develop this type of cerebral edema, interstitial cerebral edema. And always the treatment is to lower the blood pressure, to lower the CSF pressure, or increase the CPP. CPP, which is the cerebral perfusion pressure. Cerebral perfusion pressure. The cerebral perfusion pressure should be always, the normal range is always, as long as it's over 70, that's normal. And how to calculate the CPP, the cerebral perfusion pressure, we need 2 things. We need the MAP and we need the ICP, the intracranial pressure, and we need the mean arterial pressure. The mean arterial pressure, which is the systolic plus diastolic over 3. So you add systolic and diastolic, divide them by number 3, that will give you the MAP. And the MAP also is recommended to be over 60. CPP, we need it over 70. So you can get the CPP, cerebral perfusion pressure, from having the systolic and the patient's blood pressure. And if you have the ICP number, let's say patient's ICP is 21, and patient's blood pressure is 150 over 100. You will add 150 plus 100 over 3, that will be your MAP. And then you will take out of that number, the ICP deducted, which is 21, that will be your CPP, cerebral perfusion pressure. So this is the equation how to how to measure or calculate towards the CPP. Now the hydrocephalus, which is the, have you seen any especially with peds or children with large head with, especially in the back of the head, huge and large, the back of the head, right? That's hydrocephalus. That's from the CSF fluid collected, or CSF fluid is not drained, because from EMP, there is a cycle for CSF fluid produced, secreted, and then should be drained. Cycle from the ventricles in the brain, third and fourth ventricles, and goes down around the spinal cord and then goes back. So we have like a circle, right? So either there is an increased production of CSF fluid, or there is a decreased, obstruction. The outflow it's obstructed, so that it will be collected in the third and fourth ventricle in the brain. So either it's obstructed or non-obstructed, or there's another name, we call it communicating or non-communicating, hydrocephalus. So non-communicating hydrocephalus, which is, in other words, it's obstructed hydrocephalus. And this is how, as the third and fourth ventricle will be retained, or having too much CSF fluid, and it's very dangerous because that causes herniation and pressure on the brain cells, and would affect the perfusion and affects the the blood vessel in terms of vasoconstriction. And the treatment for that would be the draining the CSF fluid with we will do the what is called the shunt it to the there are different modalities, but we'll get to that in adult L3, how to treat in the patients with hydrocephalus, and probably also cover this in PEDS course as well. But the shunting will be one form of the treatment for hydrocephalus. The alterations in muscle tone, like hypotonia, and we have 4 different types of hypertonia, and I have a definition for each one. Let's see, we have paresis. So when you say paresis, means weakness. Paresthesia, which is numbness sensation. Like even with the gastric, we say gastroparesis. Even with the stomach, sometimes it's a very the peristalsis is very weak in the stomach, so we'll say gastroparesis, and that will be one of the complications in certain chronic diseases in patients. For example, diabetic may develop this gastroparesis, which is the weakness of the contractility or the pulsations or contractions of the stomach. But paralysis, which is a complete loss of the motor function. And the difference between the hemiplegia and paraplegia, right? And so the upper motor neuron will include something like hemiparesis or hemiplegia, paraparesis or paraplegia, quadriplegia, and the 4 all the 4 extremities are affected, quadriplegia. The spinal shock, because we have 2 different types of shock. We have neurogenic shock and spinal shock. The spinal shock, which is a complete cessation of the spinal cord functions below the lesion. If the patient has a, let's say, traumatic injury at the L5, for example, then the spinal shock will be below that. So it's a complete cessation of spinal cord function below the lesion. So the patient will have a complete flaccid paralysis, absence of reflexes, and that also may affect the bladder and bowel function as well. Hyperkinesia, which is the excessive movement. It can be paroxysmal or tardive. Tardive dyskinesia, it can be also would result from the effects of phenothiazine diuretics. And the most common types of these symptoms, I'm sure we have seen any patient like on phenothiazides, and they they will have what is called like repetitive movements, rapid, repetitive, like what is called a stereotypic kind of movements. Sometimes like in lip smacking or what is that? Like a twitching of the facial muscles. This kind of like what is called stereotypic movements, and it's rapid, repetitive kind of movements. That's kind of sign of what is called tardive dyskinesia, and that sometimes results from is like side effects from the psychotic or medications like phenothiazines.
Can it include like a lockjaw as well, Professor?
I'm sorry.
Can it include like like a lockjaw as well?
Lockjaws would be more of the repetitive movement of the jaw, not the lockjaw.
Oh,
Yeah,
well,
it's
from
be more of the It's hyperkinesia. It has to be like repetitive, stereotypic movement.
Okay.
There are a lot of there are too many forms of that. If you like you go to the psych or to the psych meds, you'll find this is one of the most prominent side effects of the psychotic medications. And there are too many forms of that. We have like pseudo Parkinsonism, we have the akathisia, tardive dyskinesia, acute dystonia. There are too many. But the tardive dyskinesia is very connected to to many diseases, but mostly to as a side effect of psychotic medications. Huntington's disease, which is genetic, and I think we alluded to this, or at least mentioned it in the indicated to the disease in the genetic lecture, and we said it's a autosomal dominant disorder, and it will be present in all generations because autosomal dominant, and it's results from the severe degeneration of the basal ganglia. The signs and symptoms would include like abnormal movement and progressive dysfunction of the intellectual. So the intellectual and thought processes will be severely affected, especially patient become demented. So dementia is one of the outcomes or one of the manifestations of this disease of HD. Other manifestations will result in the ballism, which is like flanging the movements. We have too many forms of that too, especially affecting the lower extremities. Hypokinesia, which is but when you say ballism, which is a hyperkinetic involuntary movement disorder. Hyperkinetic involuntary movement disorder characterized by these flanging movements can affect the limb, mostly the limb, and most of the time it's associated with lesions in the brain. Hypokinesia, which is decreased movement, so which affects the voluntary muscles. Parkinson's disease. So patients develop Parkinson's disease due to, let's see if we have here. Okay, so the Parkinson's disease will result, first of all, it's a neurodegenerative disorder of the extrapyramidal system. Now, it is associated with the what is called acetylcholine dopamine ratio, or like the dopamine and acetylcholine is supposed to be working together in harmony to provide us with a controlled movement, what is called the controlled movement. So the controlled movement would result from the balance between the dopamine and acetylcholine. Let's see if we have a better, yeah, this one. So the acetylcholine, he has the plus, and then the dopamine is minus. So this is the controlled movement in a healthy person, and this one is a patient with Alzheimer, with Parkinson's disease. So healthy, you're able to like grab a cup and try to drink without no shaking, no difficulty. You can aim it to your mouth with that. Have you seen patients with Parkinson's disease, how they shake and how they're able to? Have you seen them? Right? Especially those who work in long term, they all see like this older adults, especially with Parkinson's, that are able to. First of all, depends on the on the extent or the level, or I mean how advanced their disease is. That if they're able to hold the cup, they will have a difficulty kind of drinking from the cup. They will keep shaking, right? So that which is a disturbed movement. So that disturbed movement results from the loss of balance or homeostasis, or I mean balance between the dopamine and acetylcholine. These two neurotransmitters, they work together at the brain to control the movement. Acetylcholine excite the receptor. The dopamine will inhibit the receptor. Between the excitation and the inhibition, then the resultant, which is this is the GABA receptor. This is specific receptor in the brain called GABA receptors. When the amount of acetylcholine and dopamine enough to be at the receptor, at the GABA receptor, so that will result in a controlled movement. But in patients with Parkinson's disease, we have insufficient amount of dopamine being produced by the basal ganglia. So severe degeneration of the basal ganglia, which involve the dopaminergic pathway, which will result in decreased production of dopamine. Then we have insufficient amount of dopamine, which will inhibit the GABA receptor. So we have more excitation by the acetylcholine. Resultant effect is disturbed movement in patients with Parkinson's disease, and that will be manifested when it comes to like manifestations in Parkinson's disease. It's we call it Parkinsonian tremor. So that tremor, which is Parkinsonian type, which is tremor at rest, because sometimes if you are stressed, if you work too hard, if you jog, if you exercise, sometimes you will experience some extent or type of tremor. But this one is tremor at rest. We call it Parkinsonian tremor. And then also it's associated with with that pathophysiology as the patients will have rigid muscles, very difficult to coordinate and very difficult to hold objects because of that increased muscle tone. In addition to that, also will result in the decreased motion, which is, we call it bradykinesia, which is the slow motion. So that bradykinesia, which is slowing down in terms of the initiation and the execution of movement. Attempting to hold the cup, or trying to walk, even the initiation to start walking or continue to walk, that will be also very slow and very challenging for patients with Parkinson's disease. So 3 hallmarks of Parkinson's: tremor, rigidity, and bradykinesia. There are other manifestations of Parkinson's disease, like the forward tilt. See how the posture, I was tilted forward. They have like a blank, what is called the mask-like face, no expressions. We call it blank facial expression. You can't tell from the expression if they are like, happy, or, they can't even express their feelings in terms of facial expressions. It's blank face. It's called mask-like face or Parkinsonian face. And in addition to that, they have like slow, monotonous, like repetitive, slower speech, what is called like an echolalia to some extent, but very slow. And the tremor, and then the gait. We said they have the difficulty in initiating and executing the movement, but also they have something called shuffling gait, as if like dragging themselves, like dragging their feet. They're not like walking normally. They're trying to drag themselves. So this one, and you will cover it in pharmacology. I'm not going to, this is a little, I would say, pharm related. Given that the best medication to treat Parkinson's is the Cinemet, which is the levodopa, carbidopa, because patients have a deficiency in the dopamine, so you will give them the dopamine supplement as the levodopa, and that will be combined with carbidopa. Lower motor neuron. I will focus on with the lower motor neuron something called areflexia, which is the right after the ALS, which is the areflexia or dysreflexia. I'll explain exactly what dysreflexia is, what dysreflexia or areflexia is after the ALS. The ALS, which is amyotrophic lateral sclerosis, and or it's some would the original name Lou Gehrig disease. And who was the scientist who passed I think he passed away like last year, who was affected by the ALS, the physics scientist Stephen Hawking, right? Yeah, Stephen Hawking, who was affected by the ALS, and for a long time, so for many years he was still being able to function, which means give you an indication, or at least to understand that the ALS doesn't affect the intellectual ability. It has no effect on the ability to, to think, to process the thought. And so intellectually, it doesn't affect the brain in terms of the intellectual ability. It's most will be muscular in nature. So the ALS or Lou Gehrig disease, it doesn't involve autonomic changes, sensory alterations, or cognitive changes, but it will result in spasticity, which is an increased muscle tone, hyperreflexia. Now dystonia, I'm sorry. This slide is just to differentiate between the decorticate and the decerebrate posture. These are these two postures, which is either one of the four, but A and B affecting both sides, like right and left side, in terms of length, and then C and D affecting only one side. So let's just focus on A and B. A, which is a decorticate, and compared to B, which is the decerebrate posture. In general, these two are would indicate the First of all, it's irreversible, and they will indicate a brain damage and poor prognosis. This one will give you an idea about the difference between, gaits like, spastic gait versus the scissoring gait or the cerebellar gait. TBI, traumatic brain injury. People may develop this mostly, or high prevalent cases or scenarios will be due to the firearm related injuries, motor vehicle accident, falls, assault, even sport related injuries or recreational accidents. And we have direct versus indirect force that would result in the traumatic brain, the TBI. And there's something called DAI, which is diffuse axonal injury. And that's when most of the brain cells are affected in a rotation kind of motion that would result in a DAI. And it's very dangerous, this one, in terms of the complications. Brain injury can be open or closed. Open head injury, that's when the skull fracture, like there's a skull fracture, that is open head injury. Closed head injury would be when the skull is intact, there's no fracture, but blunt trauma. But which one would be more serious? I mean, both are dangerous, but which one would be more dangerous, more serious? The open head injury or the closed head injury? And why?
Would it be closed head, Professor?
Okay, closed. Because
the brain, if the brain swells, it wouldn't have anywhere to go.
which means ICP.
Right.
Yeah.
All right.
Intracranial pressure. Again, this is a completely closed vault. There is no any exit. So any change or any increase in ICP and the pressure inside the brain, there is no way to go.
There's no
So
right.
right. So that's why the closed head injury is very dangerous for the increased ICP. The open head injury, one of the complications would be it's open to the external environment,
Right.
which is organisms, which is open to, or I mean, patient would be prone to or at risk to develop the brain infections, especially what would you call it? The brain meninges when it's infected. When the meningitis.
Meningitis.
Yeah. Mm-hmm. So the TBI, we have a TBI and spinal cord injury is the same concept. We have a primary injury and we have the secondary injury. So here with the TBI, secondary injury would result from the after the initial injury, like after the trauma, the actual, the mechanical trauma to the brain. Then these are the physiological changes that would result, and it will cause the secondary brain injury from the hypotension, hypoxia, ischemia, brain swelling, and edema. These are the changes in the physiological changes that would result in the secondary brain injury. And we talk about the ICP, the increased ICP already. Increased ICP, and then we said, so other types of injury, we have a linear, depressed, comminuted, which is always in orthopedic or even here in brain, in head injury. It's when the skull is in the small fragments. That's fragmentation of the bone, like small tiny fragments, and it's definitely going to be depressing or causing kind of pressure and depressed on the brain tissue. That's called comminuted fracture. And depressed when part of the broken brain, skull fracture or bone broken, and then it will press against the brain. Basilar skull fracture, that's one of the
No.
worst. That's one of the worst cases, or brain injuries, or skull injuries, or brain, traumatic brain injuries, TBI. That's when the base of the skull or the fracture affects the base of the skull, and that's when one of the important for nurses to, as we assess the patient post TBI, is to see if there's any leakage of CSF fluid, like clear fluid coming out of the nose or ear. So we call that the halo sign. Halo sign. The halo sign, it's that when you see a drainage, especially clear drainage coming out of the ear, otorrhea or rhinorrhea. These are significant, I would say, manifestation to identify the patient with base skull fracture. Concussion, it can be reversible, but the patient with concussion, they will have amnesia, right? They have amnesia, a headache. Usually concussion is, when it's mild, it's will last for a short duration. And the DEI, the one I just mentioned earlier about the diffuse axonal injury, and that's when which will involve widespread axonal damage, and it's very serious, this one, because the damage will affect the around the axons in subcortical white matter, and that signs and symptoms would be like a decreased level of consciousness, increased ICP, and it may result also in cerebral edema. Contusions and lacerations. Contusions is like bruising of the brain cells or tissue, and lacerations when there is a tearing of the brain tissue. Acceleration, deceleration injury, which is very common in, in traumatic in the motor vehicle accident. The hemorrhage would result from epidural, subdural, or intracerebral hemorrhage. So the hemorrhage either between the dura and the skull, or between the dura and the under, and the brain tissue, or intracerebral, like inside the brain, within the brain tissue. So the epidural, the patients will lose momentarily their consciousness, but that will be followed by what is called lucid interval. Lucid interval, like within minutes after the injury or the epidural hematoma, they have that lucid interval. Lucid interval means that they will regain consciousness and regain all the functions, but that would be for minutes. It doesn't mean that they have been recovered, but we have to monitor them closely, at least for 24 hours. Subdural hematoma, it's either acute or subacute or chronic. It's if it lasts within up to 48 hours, that's acute. It's subacute if it lasts from 48 hours up to 2 weeks. And it becomes chronic if it's longer than 2 weeks. Lasts longer than 2 weeks, then the subdural hematoma will be chronic. Intracerebral ICH, which is intracerebral hemorrhage, and that's one form of that, which is the most common type, which is the SAH, which is the subarachnoid hemorrhage. It's a form of ICH. Subarachnoid hemorrhage is the most common type of intracerebral hemorrhage, and it's very significant, this one, because it may produce significant brain edema and elevated ICP. Now, spinal cord injuries, there are different types of injuries, of spinal cord injuries. Either it's compressing, that is like compression against the spinal cord. It could be like a pulling force or a shearing force. And if the spinal cord is completely cut, what would you call that? Complete cut of the spinal cord. We call that transection of the spinal cord. Transection. So the most common locations, it depends on the location, like cervical, 1, 2, or 4 to 7, and then the thoracic 1, T1 up down to L2, lumbar 2. And there are different forms of the spinal cord injury. Is it like compression? Is it like from the top down, like a pressure on the head? Is it a twisting? Or, I mean, due to twisting? And same principle here, like what we had in the TBI, also here in the spinal cord injury, we have two different injuries. The first impact from the, let's say, like, traumatic trauma to the spinal cord. That's the primary injury. That's the initial impact or insult to the spinal cord. Cord compression by bone displacement due to the fracture, for example, or the vertebrae. Primary injury because of the interruption of blood supply to the cord, because there is a traction from the pulling on the cord. This is a primary injury, which is the insult that will result, or the changes to the brain, to the spinal cord tissues from the initial impact or the physical impact. Step wound, gunshot, mechanical disruption of the axons due to the laceration, traumatic motor vehicle accident. So that's the initial impact. Now the secondary injury, that takes time, hours. That's why we will say that the best practice is to give steroid within the 6 hours from the onset of the primary injury, so we can prevent the secondary injury. So steroid like dexamethasone should be given within like 6 hours from the initial injury, so we can prevent the secondary injury. Because the secondary injury would result from these factors: free radicals, ischemia, lipid, peroxidation. So it takes, I would say, like after 6 hours, you will see the significant impact of these on the spinal cord, and that will result in what is called the secondary injury, which is due to the metabolic and cellular events, metabolic and cellular events that lead to the spinal cord ischemia and hypoxia, which is in this case called secondary injury. So that's it's important that as we had started to take care of a patient with spinal cord injury, to prevent this secondary injury by making sure that the drug is given or administered within 6 hours from the onset of the injury. The spinal shock and how it's different from the neurogenic shock. The spinal shock is characterized by the decreased reflexes, the DTRs decrease or absent, no sensation, loss of sensation, flaccid paralysis below the level of injury, and it may last up to 3 months. 50% of people with acute spinal cord injury, they experience this type of shock, spinal shock. However, the neurogenic shock, which is characterized by hypotension, bradycardia, and warm, dry extremities. And that's because of the loss of the sympathetic innervation. So the loss of vasomotor tone, which means vasodilatation, will result in these manifestations. Autonomic dysreflexia, which is or you can call it areflexia or autonomic hyperreflexia. It's all interchangeably used concepts, I mean terminology terms. You can say dysreflexia or autonomic hyperreflexia or areflexia, all the same. Now, who will be affected, or this is a complication that can be prevented to some extent by nurses. Knowing, the factors that may precipitate this detrimental complication. First of all, patients with spinal cord injuries at the T6 or above, they will be at risk to develop this complication. Second, knowing the factors that may precipitate the dysreflexia. Can I give you just few examples? We have a long list of examples. Just the three main ones and most common ones will be bladder distension, urinary distension, fecal impaction, like constipation, and the third one, tight clothes. And let's give you another fourth one, which is, these are the most common. We have too many. This is just the short list of factors. Again, the urinary retention, and this is obvious if patients, is supposed to do the straight cath because they are paraplegic, and they forget to do that, then it will have lots of urine retained in the bladder that could stimulate this reflex. If they are fecally impacted, constipated, they haven't done like bowel training, and they are not following, right, the protocol, then that could result in constipation, or that it will be precipitated also if there is like an air draft in the room. The fourth one, I said, tight clothes. Tie or, tie. So these are I would say the most common, and then one of the most prevalent factors. So we always have to take care of all, these factors and other factors too, but just to stick to these, like, concise list. Knowing that these factors may precipitate this problem, so we have always to address these kind of, not present. We have to prevent them from happening, right? Otherwise, if the patient, became constipated, or, urinary retention, or if there is an air draft in the room, if we are like, tight clothes, that may precipitate this problem. I know that the mechanism is quite like, very intense and complex. I'm not expecting that you will, you have to not understand, but I mean that it's very complex, mechanism. But just to know that the signs and symptoms, the mechanism involved these three things: the reflex stimulus to major sympathetic outflow, it will result in a vasospasm, significant elevation of blood pressure, and the lower extremities, you will find that the skin is paler, and the skin of lower extremities, skin pallor, and then the upper extremities, because of that autonomic response to hypertension, will result in arterial dilatation, flushed skin that will be in the upper extremities. So upper extremities, flushed skin, pale skin, lower extremities, face and upper extremities sweating. In addition to that, patient will have a bradycardia because of that vagal or vagus nerve stimulation. So from the reflex stimulus to sympathetic outflow, there will be a vasospasm, elevated blood pressure, pale skin of the lower extremities. The vagus nerve stimulation will result in bradycardia, and then the autonomic response to the hypertension would result in arterial dilatation, which will be presented in what is called, in a flushed skin in the upper extremities, in addition to the, and face too. Upper extremities and face flushed and sweating as well. So I'm not going over the, the mechanism how the patient developed the areflexia or dyslexia, but I want you to conceptually understand it in terms of the precipitating factors and how to prevent it, and the associated mechanisms, the three main mechanisms associated with them. CVA, I will just spend the last 10 minutes because I know that we are running out of time, but I have to make sure that, you know, at least I cover the CVA or stroke. So the CVA or stroke, which is what is called the brain attack. Sometimes we refer to it as a brain attack. And on the previous slide, you'll find modifiable versus non-modifiable risk factors and the pathophysiology. The blood is supplied, one of the blood supplies to the brain by two major arteries, internal carotid artery and the vertebral arteries. So the two main arteries are in which they supply the brain cells. So any interruption to these arteries, the ICA or the VA, is going to result in decreased perfusion to the brain cells. Spasm, blood clot, in this case will be CVA stroke, cerebrovascular accident, we'll see CVA or stroke the same. It can be interchangeably used kind of terms, CVA or stroke. It can affect the right side or the left side. First of all, the brain cells, the neurologic metabolism will be altered if there is an interrupted blood flow to the brain cells, like interrupted blood flow to the brain cells, perfusion. That would result in 30 seconds, you'll find a neurologic metabolism alteration. If it lasts for like 2 minutes, it will result in the metabolism will completely stop in the brain cells. And that could result in cell death of the brain cells in about 5 minutes. That's why we all say that, you know, do not exceed the 5 minutes when in any case or scenario with the brain cell perfusion. If the perfusion stops for longer than 5 minutes, that will result in brain death. So now, ischemia, when you say perfusion, you know, decreased perfusion, which means ischemia. So in response to the ischemia, so there are like a cascade or what is called the ischemic cascade will occur. Loss of homeostasis and down to the cell death. That's when the perfusion stop longer than or last the interruption of perfusion or blood supply longer than 5 minutes. Within 30 seconds, we said that there will be alteration in the metabolism in the brain cells, and then the metabolism would stop after 2 minutes, and then once we pass the 5 minutes, that would result in cell death. Now, in terms of factors that would result in CVA or stroke, something called AFib, atrial fibrillation. Any explanation why patients with atrial fibrillation would be prone or susceptible to develop the brain attacks or what is called the CVA or stroke?
They're more prone to clots.
The mechanism how patients with atrial fibrillation would be at risk to develop the stroke or CVA. I'm not sure if you have seen or had took care of patient or had experienced a patient with AFib. They will be on blood thinners. Anyone had a patient on blood thinners because of AFib? Right? So
Yeah,
blood thinners, right. So anticoagulant and afibrillation, the explanation for that would be the atrial fibrillation, which means the atria the blood in the atria is going to be stagnant and pooling. Lots of blood will be pooled and retained in the atria because the atria is not unable to contract normally. So that will be like, what is called the quivering function of the atria, not contracting, which is called the atrial click. We'll cover this in the cardiovascular, called atrial click, which is the normal contraction of the atria to empty the blood into the ventricles, right? That's during the ventricular diastole. So atrial click, so she's supposed to empty the blood into the ventricles. Now with the atrial fibrillation, that results in that the atria would be quivering. It's not like normally functioning, so that will result in more blood stagnant and retained in the atria. And anytime you will have blood stagnant and pooled, then there is a high risk for blood to clot. And we also will cover this again, under the mechanism for blood clotting in the hematology chapter. So the blood clot would be at risk to develop due to the pooling and stagnation of blood in the atria in response to the atrial fibrillation. And that's why patients with afibrillation or AFib should be on blood thinners to prevent blood clotting. Because if the blood clot in the atria, it could travel up to the brain and result in brain attack, or what's called the stroke. And this one will be called embolic stroke, because it's like an embolism, right? Because the embolism, it's a blood clot or any object, can be just any object, not just a blood clot, that which travels to the brain, like DVT, patient, right, who had experienced or survived a DVT, or being treated for DVT, and ambulating, and then the resulted in dislodging of the blood clot and travels to the brain. That is embolic stroke. So we have a hemorrhagic stroke, embolic stroke, or what is called thrombotic stroke. Now, the thrombotic stroke, which is a blood clot that has formed in the brain cells, yeah. So we have the classification would be two, let's just put it as two main classifications. The ischemic stroke, which combines both thrombotic and embolic. And then we have a totally different scenario to the different classification called hemorrhagic stroke. So the embolic stroke, I provide you with two examples of embolic stroke. The first one is patient with AFib, right? Blood stagnant in the atria. That will precipitate or, will put the patient at risk to develop the blood clot in the atria, and then that blood clot could travel to the brain, and then the patient will develop the brain attack or CVA or stroke of that type, embolic stroke. The second scenario would be a patient with DVT, blood clot dislodged, thrombosis from thrombus or blood clot dislodged from the lower extremities, travel to the brain, and that could result in brain attack or CVA or stroke. That is also called embolic stroke. There's two different scenarios of embolic stroke. And then we have thrombotic stroke. Thrombotic, that's when the blood clot formed already, like in the brain cells or in the brain, like blood vessels. And then we have the hemorrhagic stroke. So under the ischemic stroke, you can put under ischemic as one major classification called ischemic. Under that, you can put the thrombotic and embolic under that ischemic. And then a totally different classification called hemorrhagic, because when it comes to treatment, we will treat patients with ischemic stroke, totally different patient than patients with hemorrhagic stroke. You will never use a TPA or a blood thinner or anticoagulant for patients with hemorrhagic stroke, right? You will definitely use it for embolic or thrombotic, which is ischemic. Anticoagulant blood thinners will definitely be used, or TPA, tissue plasminogen activator, which is a thrombolytic agent or medication, will be to treat patients with ischemic stroke, thrombotic or embolic. But for patients with a hemorrhagic, you will never use these medications, because that will put them at higher risk they already have that bleeding. And if you give them the blood thinners that will make even the condition even worse. So the last thing, I know as we have, we passed the time, like a few minutes after, but I'm trying just to get everything done. So read, through and I can post the answers for the case studies and the questions on the Blackboard. Yeah, the last two things will be the MS and the MG. Those are the two most important ones, the MS and MG. Let's see if we can do that. Either we can do it on Friday, because I would like to start a new topic on Friday, like endocrine system. I know that, I'm kind of maybe rushing, but it's, I can or maybe record the remainder of the lecture, so we can so we'll have like 3 recordings or recorded lectures for a neuro, so we can start the endocrine on Friday, because otherwise we'll start with the endocrine system and neuro, continue with neuro, and then endocrine will be like 2 different topics in one recording. So I will definitely record like a short one about the MS and the MG and the GBS, the Guillain-Barré syndrome. And then Friday, we will start with the endocrine system.